The title of this webinar is Meeting Healthcare Needs of Children and Youth in Foster Care.
Good afternoon, everyone, and welcome to today's webinar. I'd like to start with some housekeeping items. All participants will be on mute throughout this presentation. This webinar is being recorded and will be available on the collaborative website for viewing soon. We will have a Q&A session towards the end, and participants can use the Q&A feature on the GoToWebinar panel. Please type in your question, and we'll be happy to respond. I would also like to note on the handouts feature, you'll note that there's 2 PDF handouts. We can provide those at a later time. At this time, I will turn it over to Paula Kienberger of the Children's Bureau.
Thank you, Christy. My name is Paula Kienberger, and I'm the National Foster Care Specialist at the Children's Bureau under the Administration for Children and Families. I would like to first thank all of you who have joined us today as participants. I'd also like to thank the Center for States for supporting putting this webinar together, and I'd like to especially thank all of our presenters that you'll be introduced to just shortly. In March of this year, the Government Accountability Office released a report that was titled, "Not All Children in Foster Care Who Were Enrolled in Medicaid Received Required Health Care Screenings." And we'll actually provide you a link to that report as part of this presentation. So under the Social Security Act, each state is required to develop a plan for ongoing oversight and coordination of health services for children in foster care, which includes establishing a schedule for initial and periodic screenings. Screenings may include medical, dental, hearing, vision, mental health, and other assessments such as developmental assessments. And the state plans must address 7 specific elements that are provided within the Act. So the Government Accountability Office reviewed a random sample of 100 children in foster care and enrolled in Medicaid for the time frame between July 1st of 2011 and June 30th of 2012. This was based on 4 states with large foster care populations, which were New York, Illinois, Texas, and California. And that was to determine whether children in foster care received initial and periodic health screenings as established in their state plans required under the Social Security Act. The report highlighted that while children in foster care often experience chronic medical, developmental, and mental health issues that require early and frequent assessments and treatment, nearly 1/3 of the children in foster care that were part of the sample and who were also enrolled in Medicaid did not receive at least one of their required health screenings. In addition, for these children, 12% did not receive the initial screening, and 17% received at least one of their required screenings late, according to the time frames that were established through the state plan. Since it is critical for states to ensure that children and youth in foster care receive needed health services, we'd like to focus through this webinar on how child welfare, the courts, and healthcare systems can work together to improve the health care outcomes for children and adolescents in foster care. Today we'll provide state examples from California and Illinois who were part of this GAO report and study, with state representatives highlighting how medical services are provided for children and youth in care, as well as an overview of aftercare health services for children and youth returning home or transitioning from foster care. So I'd like to now turn the webinar over to Millicent Williams from the Center for States.
Hi, thank you so much, Kathy. I am Millicent Williams. I'm the Program Area Advisor for Foster Care and Permanency at the Capacity Building Center for States, and I, too, would like to welcome you to our webinar. As Kathy mentioned, we have 4 expert presenters today who will share their expertise and long years of working on this topic of health care for children and youth in foster care. And each presenter, I'm going to let them actually introduce themselves at the time of their presentation, but each one will have their contact information available, and we will have a question and answer session in order for you to explore more with them. Before I move to the presenters, who I want, again, just thank them so much for being available, I wanted to just tell you a little bit about the Child Welfare Capacity Building Collaborative. So the collaborative, as you can see, it's a partnership of 3 centers. And there's the Center for States, the Center for Tribes, and the Center for Courts. And we are a service of the Children's Bureau, part of the U.S. Department of Health and Human Services. The next slide will show you the collaborative members that I just spoke about, and they are, again, as we mentioned, states, courts, and tribes. And the important thing here is that all of the centers really work collaboratively, such as the name implies, to provide experts in all practice areas, and the main goal is to achieve capacity building for the participants and the states and tribes. And it's a partnership. That's the main thing. So you can see the goal of the collaborative is really capacity building through partnership. And I know I've said that word a couple of times, but it really can't be said too often, is that we feel that in order for states, tribes to enhance their practice, we really need to do it through partnerships, such as a little of what you'll hear in this webinar today, in how systems and child welfare came together in order to provide the best health care services for our kids in care. The next slide wanted to refer you to the collaborative website. This is right there at the bottom of the slide. You see the link.
The URL for the Child Welfare Capacity Building Collaborative is https://capacity.childwelfare.gov.
And we ask that you go to the site periodically. We are always updating the site, and we're hoping and knowing that it will provide the resources that you need in order to do your work, and we are constantly adding to the site. Now just a little bit on the specifics of the Center for States, which is the center that's supporting this webinar along with the Children's Bureau today on health care. The Center for States supports public child welfare agencies in their efforts to provide practice changes in order to better serve the families that they're working with. The issue for us here, and the next slide when you get a chance, the issue for us here is that all work focuses on sustainability. We want change in child welfare that's not just here today and gone tomorrow, but sustained change for our kids and families who deserve that. The Center for States' goal, as you'll see in the next slide, is really to use the approach of evidence-based capacity building services for the child welfare field.
Center for States goals. Number 1, improve system, organizational, and program performance. And number 2, significantly enhance safety, permanency, and well-being of children, youth, and families.
Again, you'll see what Center for States does is support child welfare agency in effectively initiating and sustaining change. So again, there's that word sustaining. That's the key to the work that we're doing. The other piece of work for the Center for States in the next slide you'll see is the services that we provide are targeted in 3 areas. Universal services.
Universal services enhance the awareness, understanding, and engagement of child welfare professionals to increase their access to and use of information to provide quality services to children and families.
There's also constituency services, which I do want to have you focus on, that these are specifically targeted to peer group enhancement. Various groups of you out there, whether it's foster care managers, adoption managers, etc., will have access to these services and an opportunity for you to really network together. And then we have tailored services. And this supports the states, tribes, and territories and courts by strengthening performance. So these are our three targeted areas that you will have access to in terms of the work that we're doing. And then finally, so that we can get to our presenters, the next presenter will be Eva Klain, and Eva will speak to healthcare needs of children and youth in foster care. So thank you. And Eva, it's your turn.
Thank you so much, Millicent, and it's a pleasure to be here with you all today. I am here both in my capacity as a liaison with the Capacity Building Center for Courts, and similar to the Capacity Building Center for States, which Millicent just described, we work with court improvement program projects and the courts and provide universal constituency and tailored services, working with the courts, as our name implies, to build capacity in child welfare. And so as in my role as liaison and also as Director of Child and Adolescent Health with the ABA Center on Children and the Law, I am going to talk today just generally about health care for children in foster care and then go over some of the federal statutes that directly address how the child welfare system should respond to children's health care needs. So you will hear a lot today about some of the health-related issues facing children in the child welfare system and whether their health is compromised as a result of their abuse or neglect or whether their health led them to the need for state intervention. There's no doubt that children in foster care have significant health care needs. Approximately 35 to 60% of children in care have at least one chronic health care condition that needs treatment. So this may be growth failure, asthma, obesity, vision impairment, or hearing loss, neurological problems, or other complex chronic illnesses. And at the same time, as many as 50 to 75% of children in care show some behavioral or social competency problems that warrant mental health services. And unfortunately, they often do not receive the basic health care that they need. As was described in the GAO report that was mentioned earlier, many children are just not receiving the screening and the health care that they need, and especially given their higher rate of complex health care needs. So we know that comprehensive and coordinated health care is a critical component of children's well-being, and it's also critical to their long-term outcomes. So I just want to emphasize that virtually all children in foster care are categorically eligible for Medicaid, and Medicaid agencies are therefore so important to the development of solutions to the issues facing this population. And federal child welfare law also requires cooperation between state child welfare agencies and Medicaid agencies to ensure that the health needs of this population are properly identified and treated. So as a result of their Medicaid eligibility, children in care are entitled to EPSDT services, which are early periodic screening, diagnosis, and treatment services. And those are listed here on the next slide, and they include immunizations, hearing, dental, vision, lead exposure screening, and physical health care and mental health care. And as I mentioned earlier, because their health needs are greater, and in recognizing this, the American Academy of Pediatrics recommends greater supplemental visits at what they call critical child welfare junctures for children who are in foster care. So it's an increased schedule for screenings and checkups that children in the general population would not necessarily need. So our next slide shows what those recommendations actually are. And these include when the child first comes into the system, because many maltreated children have not had adequate health care and may not have been previously seen by a doctor prior to their entry into care. Whenever there are placement transitions, again, we try to keep placement stable, but a single medical home provider can provide consistency during a placement transition. And whenever there is a transition, it's important for that child to be seen by a provider. And then any significant changes in home environment that might impact the child's health, any significant issues related to visitation, which also may affect mental health or behavioral considerations. If there are any clear signs of abuse or neglect, they should also be examined. Any deterioration in behavior or developmental skills or in their health itself. And then also when the child is discharged from the child welfare system. So when there's a system exit is also an appropriate time. And as mentioned earlier, states do have their own schedules identified in their plans, but these are just recommendations that the AAP has put out in regard to children in foster care. And I do want to talk a little bit about trauma and health, because trauma has received quite a lot of attention, both within the child welfare system and generally in terms of children's exposure to violence. And so on the next slide related to trauma and health, I just want to talk about a traumatic event, which is an event that threatens the life or physical integrity of a child or of someone who's critically important to the child, such as a parent or a sibling. And the resulting traumatic stress that the child feels refers to the physical and emotional responses that child has to that traumatic event. And when there is an absence of positive coping strategies, when there's not an intervention or some assistance in helping that child to cope with that traumatic experience, the child may engage in high-risk or destructive coping behaviors, and these behaviors place them at risk for a range of serious mental and physical health problems. And these might range from alcohol use and abuse, drug use, depression, suicide attempts, sexually transmitted diseases. And also studies have shown higher rates of heart disease, cancer, and all sorts of other chronic health conditions that result from that trauma exposure. So how can we address these resulting health issues? We can do that by recognizing the impact that current or prior exposure to violence and trauma has on the physical, emotional, psychological, and behavioral development and well-being of children. And the system can then respond in a trauma-informed way that reflects the awareness of trauma's adverse impacts. And some, now call for trauma-responsive approaches, not just trauma-informed, that the response needs to be trauma, has to have trauma in mind in terms of going a step beyond just the knowledge that there was trauma. And then we can also act in collaboration with other professionals involved with the child or family to facilitate and support their recovery and resilience. So having identified some of these health needs, I wanted to address some of the federal statutory requirements that address them. So on the next slide, I have listed several of the acts that address health in some capacity. And, of course, we want to build on the importance of well-being under the Adoption and Safe Families Act. So ESFA certainly highlights well-being, and there's been an increased focus on well-being within the states and by the federal government, including information memoranda and guidance and various convenings that address the well-being measures. And other laws that also play an important role are the Fostering Connections to Success and Increasing Adoption Act, which was designed to promote high-quality, comprehensive, and coordinated health care services. And then Fostering Connections was followed by the Child and Family Services Improvement and Innovations Act. And, of course, in the middle of this mix came the Patient Protection and Affordable Care Act. And I'll take a little more time in a minute to talk about its potential impact in just a minute. And then finally, I want to address the several provisions of the Preventing Sex Trafficking and Strengthening Families Act of 2014, which actually also has several provisions that relate directly to health. So going back to Fostering Connections, the Act requires states to develop a plan for the ongoing oversight and coordination of healthcare services, including mental and dental health. The states, under their Title 4B plans, had to develop the plan in cooperation and coordination with the state Medicaid agency and in consultation with pediatricians and other health experts. So now the plans must describe what initial and follow-up health screening is provided, how the identified health needs are monitored and treated, and how medical information is updated and shared appropriately. And Fostering Connections requires the state plans to detail what steps are taken to ensure continuity of healthcare services for children, and also including the possibility of a medical home for every child in care. And I do want to take a minute to address medical homes for children in foster care, a concept that's also going to be, it's also addressed in ACA, and I know Dr. Szilagyi will be addressing this in much greater depth following me. But because so many children in foster care with complex medical needs or enter with so many complex medical needs, and once they're in care, they may experience multiple placements or lack access to needed services or have unknown medical histories when they enter care. It just makes it that much more important for a knowledgeable medical home provider to provide care for this population and to assist with all those transitions. So building on the Fostering Connections Act, the Child and Family Services Improvement and Innovations Act required more information in state plans about the appropriate use and monitoring of psychotropic medications and how states will address the trauma associated with abuse and neglect. So the 4B state plan was already required to have a section on the ongoing oversight and coordination of healthcare services, including the physical, mental health, and dental health for any child in foster care. And the Act modified that language to require trauma related to the maltreatment and placement as an additional consideration to be addressed. And then the same section of the plan also requires an outline regarding the oversight of prescription medications that includes protocols for the appropriate use and monitoring of psychotropic medication. So some provisions of the Affordable Care Act that also have a direct impact on children in foster care. And the Fostering Connections Act required detailed transition plans to support youth who are aging out of foster care, and the ACA builds on that requirement to require information about health care and transition plans. So this includes information about health insurance options and the importance of designating a health care power of attorney or health care proxy to make decisions when a youth in care can't participate in those decisions or becomes incapacitated. And, of course, one of the most significant provisions of the ACA is the extension of Medicaid coverage for former foster youth to age 26. So beginning of January last year, states had to provide Medicaid coverage to up to age 26 to all youth who have aged out of foster care. And to be eligible, the youth must have been in foster care on their 18th birthday and have been receiving Medicaid at the time. And if eligible, they receive all Medicaid benefits, including EPSDT, which listed, and I listed some of the services that are provided under EPSDT earlier. And, of course, there are other ACA provisions that also apply. They aren't directly focused on youth in care, but they certainly assist youth in care in a more global way, and those include expanding Medicaid and the Children's Health Insurance Program, promoting oral health, funding home visitation programs, which of course help with prevention efforts, and then promoting health homes, medical homes, and I already mentioned the power of attorney or health care proxy. And then finally, I just wanted to talk more about the latest act, which is the Preventing Sex Trafficking and Strengthening Families Act of 2014. And this act was signed into law by President Obama on September 29th, 2014, and it takes many important steps toward protecting and preventing children and youth in care from becoming victims of sex trafficking, but it also makes many important improvements to the child welfare system that will help improve outcomes for youth in care, and especially related to health. And before I talk about the two sections that are of particular importance for children's health, I do want to note that Section 101, which is on identifying, documenting, and determining services for children and youth at risk of sex trafficking, has a direct impact on the health of so many youth who have been trafficked. So certainly providing trauma-informed, gender-specific services to address both physical and mental health issues resulting from their exploitation can have a direct impact on their well-being. So the first of the health-related sections that I wanted to raise was Section 113, Youth Empowerment and List of Rights Notification. So this section allows children who are 14 and older to help develop their own case plans. And that case plan must also include a list of rights document that describes their rights with respect to education, health, visitation, court participation, staying safe, avoiding exploitation, and also regarding some of the documents that are described in the next section, which I'll address in a minute, and that those documents also include vital health information. So the youth must sign off that he or she has received this document, and also, very importantly, that it was explained in an age-appropriate manner so that the youth could understand the significance of those rights. And then Section 114, which is the key documents for youth aging out of foster care. This section addresses key documents that are required to be provided to children. So children exiting foster care at age 18 or 21, if the state extends foster care, and who have been in care for at least 6 months, receive an official or certified copy of their birth certificate, a Social Security card, health insurance information, medical records, and a driver's license or identification card if the child is eligible for those documents. The courts can also play an important oversight role in ensuring that youth receive these documents. And in regard to the health insurance information specifically, the law does not specifically require that the notification include foster youth's eligibility for Medicaid coverage to age 26 under the ACA. However, the agency could provide verification of the child's name, birthday, dates of time in care, and whether the child was in foster care on his or her 18th birthday, and whether he was eligible for Medicaid. So the Fostering Connections Act already requires health oversight and coordination plans to provide information about the options for health insurance, which should include details about eligibility for Medicaid through age 26 and other options. As for medical records, the law does not state what documents specifically should be included or what time frame they should cover, whether limited to their time in care or also including medical information from before they entered care. But as much information as possible and available would clearly be beneficial to the young adult as he or she ages out of care. So that ends my description of some of the federal statutes that apply, and I want to thank you, and I look forward to any questions you may have. And also here is my contact information.
Eva can be reached at the Capacity Building Center for Courts. She can be contacted by phone at 202-662-1681 or via email at eva.klain@americanbar.org. Feel free to visit the American Bar Association's Center on Children and the Law website, www.americanbar.org/child.
Thank you.
Hi, this is Moira Szilagyi. I'm a pediatrician. I'm currently a professor of pediatrics at UCLA, although I spent almost 30 years in Rochester, New York, where I was the medical director of Starlight Pediatrics, which is a medical home for children in foster care. I'm also chair of the American Academies of Pediatrics Council on Foster Care, Adoption, and Kinship Care. And today I'm going to be focusing, I'm going to repeat a little bit probably of what Eva and Millicent both said, but really focusing on pediatric medical homes for children in out-of-home care, whether in foster or kinship care. And so this applies to all of those children, and why they're so important in particular for this group. So my outline is, why are these medical homes important for children in out-of-home care, which is partly federal law that Eva's already discussed, but really the characteristics of the children really drives the importance of this. And describe a little bit what we mean by a pediatric medical home and what is special about the medical home for children in out-of-home care. So on the next slide, probably the major characteristic of children in out-of-home care that makes it important that they have a medical home is that they are such a transient population with multiple caregivers. And they've often had multiple caregivers even prior to their entry into the child welfare system. So many times, no single caregiver has the complete health history, and particularly if it's a new caregiver, they're unlikely to have any health history, and child welfare often doesn't get much in the way of health history at entry to care. And then there's often when a change in caregiver occurs, that's often accompanied by a change in health provider, which, if the child's really attached to a true medical home, should not happen. And then, of course, this high level of transience is the impact of disruption of the primary attachment figure multiple times over. Really takes an emotional toll on children over time. On the next slide, the second major reason or second major characteristic is this burden of childhood trauma and loss, which is really high in this population, and it really impacts all aspects of their health, their physical health, their developmental health, under which I include educational, and their mental health and well-being. So on the next slide, the physical health, and this is really just a very brief summary. So how does trauma impact physical health? Sometimes the physical health findings are the direct result of child abuse or neglect. So neurological sequelae of shaken impact syndrome, or the sequelae of neglect in terms of poor weight gain and growth. But there can have been prior neglect of existing medical and dental problems. So children who come into care with multiple dental cavities, which is probably the most common infectious disease of childhood these days, and medical problems such as diabetes or obesity that may not have been attended to appropriately in their prior setting. And then flares can occur even in physical health problems that are related to times of stress in a child's life. And so, for example, asthma may flare in response to emotional distress, as may eczema. And then mental health, you probably all are very aware that about 80% of children in good systematic studies that have been done enter care with a positive mental health screen, and about 80% of those will, upon further evaluation, have an identified mental health problem that requires or makes them eligible for services. And I will say that many children are getting evaluation these days, but there is still a real disconnect in attaching children to needed and appropriate trauma-informed mental health services on an ongoing basis. And developmental health, in those studies that have systematically looked at children under the age of 5 and their developmental problems, 60% of toddlers and 80% of preschoolers basically present with a developmental delay in at least one domain. And the most common domains are in the social, emotional, the communication, and cognitive areas, and then fine motor. Gross motor is usually fine unless the child has a multiply handicapping condition. And in the school-age population, there are many, many school issues for these children, but 40% or more in well-done studies actually would qualify for special education or additional resources, educational resources. So the next slide shows that one of the other characteristics of these children is that they have often received fragmented health services even prior to entry to child welfare. So we know, looking at the next slide, not only do we have the GAO data, but in New York State in 2013, Phyllis Silver and Fred Wilson published a study looking back at 7 years of Medicaid data for children coming into foster care, and they looked at children the year prior to entry, during their time in foster care, and then the year after discharge from foster care. So less than 30% of children in that study, and it involved tens of thousands of children, had received any preventive health services the year prior to placement. The first year of placement, about one-third of children in that study received a preventive health visit. Now, and this population included kids from birth through 18 years, and infants are supposed to have 6 to 7 health visits, preventive health visits in their first year of life. And so even with this representation by young children in this study, these numbers were really abysmally low, and actually even worse than the data in the GAO study. They also tend to be high utilizers of emergency room and inpatient care prior to foster care, and this persists even after foster care. And in those places where there are good medical homes for these children, one of the very first things that we see is that emergency room and inpatient use actually go down. And so this not only saves money, it's probably much better care for children. We also find that at entry to care, in well-done studies, that not all problems have been diagnosed previously, and even if they've been diagnosed, they have often not been treated adequately. So this fragmentation of health services persists beyond. And then, as Eva already mentioned, they often enter care without any health information, and sometimes without their medications or equipment such as glasses and hearing aids and asthma nebulizers and an immunization record. We've gotten a little bit better with immunizations because most states now have immunization registries. And so as long as physicians' practices are good at entering that information, we can usually at least find an immunization record. But most children, I would say probably it used to be about half of children entered care unimmunized 20 years ago, and it's probably closer to 30% enter now under-immunized. So moving along to the next slide, just again reiterating that federal law, the Fostering Connections to Success Act of 2008, that states really are required as part of developing health systems to really make concerted effort to connect children to medical homes during their stay in care. And that, of course, brings us to the question of what is a pediatric medical home? Next slide. Can I have the next slide, please? So a medical home is actually a pediatric practice. It is one that provides patient-centered, family-focused care that meets certain criteria. It should be accessible, provide continuity of care over time, provide comprehensive pediatric services. It should be compassionate, culturally competent, and in the case of this population, trauma-informed. Well-coordinated care with good communication among partners. And so I'm going to go through each of these kind of one by one. So what is accessible care? And on the next slide, you can see that accessible care, if you can just keep going to the next slide, please. The accessible care is care that is close by or easy to reach, through transportation, that accepts the child's health insurance. And most children, the vast majority of children in foster care at least, if not in kinship care, are covered by either Medicaid or Medicaid-managed care. But not all pediatricians accept those insurances. So making sure that the pediatrician identified or the family medicine doctor identified actually accepts the child's health insurance is very important. Provides 24/7 coverage, so has after-hours coverage. And in the case of the medical home for the child in foster care is what I call foster care friendly, that there's some kind of relationship between child welfare and the pediatric staff, and that the pediatric staff at least has contact information for the child welfare system in their community. And there are other components to this that will kind of come out during the next sections. So going back to the original list again on the next slide, the next item on that list is continuity of care over time. And on the next slide, there's a definition of what this means. And that means that ideally the child is followed by the same health provider before, during, and after out-of-home care. Many of these children, however, enter care having had no medical care for several years, or have switched providers multiple times, or really can't identify who their health provider is. And so while they are in foster care or kinship care, it's important that at least during the period of time while they are in out-of-home care, that regardless of placement change, that there is one health provider who is responsible for their health care. And then the next item on the list for continuity of care, after continuity of care, is providing comprehensive health care. And on the next slide, you can see that comprehensive health care really means providing preventive and acute care and chronic health care according to the American Academy of Pediatrics guidelines, not just for the child and the general population, but in addition to those recommended care guidelines by the American Academy of Pediatrics. And the guidelines are called Fostering Health. They're available on the AAP website, and there'll be a link provided for you at the end. And some of the provisions of that are that these children have an initial health screen within 72 hours of placement, that they have a comprehensive health assessment, which includes their physical health, developmental health, which includes their educational health, their dental health, and their mental health within 30 days of entry to care. It's really kind of important that the mental health and the developmental assessments probably occur after a period of adjustment to the home, because any child removed from their family is pretty much in a state of emotional shock during those initial days in care, and really to get a good assessment, one would have to wait for a certain adjustment period. The health screen, the early one, should be used to rule out any acute needs in those areas, but the more comprehensive assessment needs to occur after an adjustment period. And then Eva already kind of went through that list of critical junctures, so I'm not going to repeat it here. But that these kids do need more frequent health visits and more frequent health monitoring. And then I put compassionate, culturally competent, and trauma-informed all in one line, because I think they're kind of all part and parcel of the same thing. And compassionate care, on the next slide is exactly what you think it means. It's empathic care in the context of the trauma and loss experienced by these children and the impact of that on both children and their caregivers, and that includes their birth kin and foster caregivers, and also their child welfare caseworkers. This becomes very challenging for them also. And it has to be with some understanding of this microculture that foster care is and its impact on children and caregivers. Foster care is supposed to be a healing, temporary healing system for children, and sometimes it can add a little bit to the trauma depending on how well it is meeting the needs of children. And also needs to be with the understanding of the child who's living in the context of multiple caregivers and families. Children often love all their caregivers, their bio and their kin and their foster, and they can often have a great deal of internal conflict around that, especially if those caregivers aren't acting in concert with each other. And then the impact of visitation, if that's not going well, court decisions, and all the other pieces of the foster care system. So the next part of the medical home is that care should be very well coordinated. And, in general care, we usually rely on the parent to do a lot of the care coordination, getting the child to a referral that we've made for them. But in this system, the child is really reliant on a whole different host of individuals to be meeting their care needs. So on the next slide, when I think about coordination, I really think that the pediatric provider in the medical home have a tremendous role here in ensuring that not only are referrals made, but that they're tracked and monitored over time to ensure that the child's gotten there, that whatever's come out of that referral, that's been followed up, monitored, and addressed, and because it's not always clear that that's going to happen. So this close monitoring and follow-up are really very, very important. And then the last item on the list is communication, and this is really where the partnership, I think, with child welfare comes in. So on the next slide, this is really effective sharing of information across systems, and this is bidirectional sharing of information because we need information from child welfare also. We really actually need to understand the trauma context that this child has experienced and whatever strengths and needs that child welfare may know about. But communication involves that partnership with caregivers and older youth also, in providing them appropriate education, providing a health summary that caregivers and youth can have available, developing a health care plan in concert with caregivers and youth and child welfare that's then shared with child welfare and available to caregivers in the court, with the goal, hopefully, that it's integrated into the child's permanency plan. And the reason why discharge planning that includes health is so important is that sometimes it is a health problem that results in a return to care that could be totally prevented. And so something that I've had occur, unfortunately, a couple of times as a primary health care provider is the court discharged the child from care. They left without our having any contact with the birth parent. Child had a seizure disorder. Parent did not understand how to administer the seizure medications. Child had a seizure, ended up in the emergency room, and a CPS referral was made, and the child was removed again. And I think in two of those cases, I think the process of providing appropriate health education to that parent and perhaps even some ongoing aftercare would have probably prevented that removal. And so this exit planning is very key and just still is not happening enough. In Rochester, New York, we had gotten to the point where we were following families up to 6 months after reunification and providing ongoing health care services and transitioning them out then to another medical home. So moving on to the next slide. The trauma-informed approach in the pediatric setting, we are trying very hard at the American Academy of Pediatrics to infuse the concept of childhood trauma throughout our 60,000 pediatricians in the United States. And it is still not common, but we're trying to get there. But for the child in foster care, providing anticipatory guidance or that advice to parents that is truly trauma-informed, and I'm going to give you 2 case examples of this in just a moment, reminding ourselves that medical problems may flare with stress and understanding what is triggering some of these flares can be very important. So I had a young lady, for example, who was ending up in the pediatric intensive care unit after visiting with her mother. And after the third time that this happened, and I finally started exploring it, we realized that the mother she had major mental health issues and was really engaging in behaviors that was just triggering this child's emotional distress, and that was her symptom was her asthma. And so once we were able to address that, we were able to prevent any more trips to both the pediatric emergency room and the ICU. The trauma-informed approach involves incredibly detailed attention to mental health assessment and management and to developmental assessment and management. Trauma impacts the brain in ways that results in major issues in these areas for children, but children can heal also if they receive the appropriate care. And then really good communication, not just with caregivers and child welfare, but also with schools and child care, the other settings where children spend a tremendous amount of time. So if we can go on to the next slide, this is just my first mini case. And this is a caregiver, and this is a very common scenario in foster care, who comes in complaining that the 4-year-old child new to their home has a great deal of difficulty settling down at night and falling asleep, and is frequently up crying, often all night. And for these families, I spend a great deal of time explaining the impact of trauma on the developing brain and how that results in hyperarousal and the dysregulation of sleep. So it's not the child's fault. This is how their brain is built. They're probably scared on top of that. And we spend a great deal of time discussing sleep hygiene, the importance of bedtime routines, reassurance, calming activities, a night light, having a real schedule that you go through. For the older kids, explaining all the noises in the house that are brand new to them and might be, in fact, quite terrifying, especially if bad stuff has happened to them at night in the past. And then occasionally, certainly not often, a pediatrician may treat with a sedating medication for several weeks until the child kind of settles into the new sleep hygiene ritual. So this is a little bit different of an approach than perhaps a general pediatrician who's not tuned into the child's trauma history might take. And then on the next slide, there's just another little case like this. Again, now it's a child in kinship care, a grandmother who notes that her 3-year-old grandson is pretty hyperactive and impulsive, but especially after visits with his mom, and he was suspended from child care after returning from a visit. And again, I spent some time explaining dysregulation and the delay in emotional regulation that occurs in the brain as a result of trauma. So again, taking the blame off the child's doing what we expect him to do. So now we need to change the environment a little bit to help this child. So this emphasis again on predictable routines. Safe ways for this child, he's very motoric, to actually expend some of his energy when he gets back from a visit. So he probably needs a reentry period that includes some gross motor play. So maybe the daycare provider needs to select somebody who helps him with reentry, and he gets to go out in the playground and run around for a bit until he calms down, and then maybe have a little snack, and then slowly reenter instead of coming right back into the fray after he's missed some of that daycare time. And the same thing is true of a child going home. Some children need a quiet period after visits. Other children need some way to expend some of that emotional energy. And preparing children for transitions, both at the beginning, going to the visit and coming back, what those periods are going to be like are very important. And then for the pediatrician and the caregiver, it's really relaying this information to the child care setting so that they are partners in this process. So then just my last slide here is just a summary of why pediatric medical homes are important for they're probably most important for children who experience many disruptions, have a high burden of trauma and loss because of its global impact on their health, because they do need closer monitoring and follow-up, and they don't often have that healthcare manager in their lives, so often that becomes part of the pediatric medical home. And then their caregivers often need additional support and trauma-informed guidance. And I will just briefly say that our medical home in Rochester was a partnership between the Department of Public Health, where it was housed, and Child Welfare. We started small, but we grew very quickly as foster parents discovered us. We were supported by a combination of Medicaid dollars and general health dollars from the local community because Medicaid just didn't fund the resources there. We did all the primary care and all the health care management for this population in partnership with Child Welfare. We had communication with Child Welfare at the leadership level as well as the frontline level. And over time, working in partnership, we were able to find funds to build a new building that housed an integrated primary care medical home that included mental health services and some developmental services and some dental services. And we were housed with the visitation center so that we could start developing connections with the birth parents and partner with them around their children's health. And we were, and the mental health providers would also provide mental health services during visitation. And we had trained all of our staff on evidence-based parenting and trauma care so that everybody was talking the same language. And but that's, I think, an unusual model, but really grew out of a partnership between health and child welfare. So thank you very much.
Good afternoon. My name is Paula Juades. I am the medical director of the Child Welfare Agency in Illinois. I'm professor of pediatrics at the University of Chicago. And we are going to talk, Vince Champagne, who I will introduce shortly, will talk about what we have done in Illinois. HealthWorks is the name of our healthcare system. It's about 25 years old. We were the first, I believe, in the nation to have a statewide healthcare system of care for our kids. And as Eva has nicely set up, you know about all the medical problems, and then Moira has beautifully talked to you about a medical home. And for us, it was our whole goal, our major goal was to ensure children in foster care have a medical home. So this all came about because of a lawsuit. Thank you very much, lawyers. And so the state of Illinois had to get its act together. So we developed HealthWorks. And I want to tell you, it was very important for us to find physicians. And the one thing that was very important is to find physicians trained in pediatrics. Those are pediatricians and family physicians, and we wanted a medical home. We asked physicians. They said, yes, we will take care of your kids in foster care. So it took us about a couple of years to establish over 2,000 physicians, qualified physicians, who said, yes, we will be a medical home for the kids in foster care in the state of Illinois. And so that was our goal. Now, Vince Champagne will go through overall the whole components of the HealthWorks service. Vince?
Yes. My name is Vince Champagne, and I for the past 5 years was the Health Policy Administrator for the Illinois Department of Children and Family Services, and I've since retired. As Dr. Juades has introduced, the HealthWorks program was something that was actually developed from a federal court consent decree, which required a number of very specific things for the Child Welfare Agency to do. One of which was to establish what we call HealthWorks of Illinois. The program is really, from its very beginning, a collaboration between the Child Welfare Agency as well as the state Medicaid agency. In our case, it's the Illinois Department of Health Care and Family Services, and the Title V agency, which is the Department of Human Services. There are other aspects of collaboration, I think, that really contribute to our experience in making this program work, which is then a collaboration that we've developed with local county health departments that administer the program in all 102 counties in the state of Illinois. Most of them are local county health departments, and they're the ones that have developed the network of primary care physicians, of which we have approximately 2,000 that cover the entire state. The other components of the HealthWorks program are an initial health screening within 24 hours of protective custody, preferably prior to placement, the comprehensive health evaluation for children within 21 days of temporary custody, linkage to a medical home, the standardization of medical records, which includes a health passport. Dr. Juades will talk a bit more about that, and medical case management services, which is a Title V maternal and child health funded program for the youngest children and for teens who are pregnant. Next slide. I'd like to first say that the requirements that we're laying out for initial health screen and comprehensive health evaluation are components that are required in our federal court consent decree. So the initial health screen is to be completed within 24 hours of our agency taking custody of a child. And the purpose is to identify and treat any acute medical issues that the child presents with, to document signs of abuse and or neglect, and to provide information to the caseworker who is working on placing the child in a home, either in a foster home or in a relative caregiver home. We've included for each of these services some of the data that we have from last fiscal year. So in 2015 fiscal year, which is for Illinois, ended at the end of June 2015, there were 4,743 cases that these were children new to our custody, and we have documentation that 84%, almost 85%, had initial health screenings completed. It's important, I think, to point out we want to include data because I think it does lend itself to some further discussion. Some would say, well, why isn't it 100%? We find that in order to fulfill the requirements, we have to be in constant communication with workers. The initial health screening is primarily a responsibility of a child protection investigator. We have to be in contact with those staff, particularly provide training for those staff to understand these requirements. We also have to make sure that they connect with the appropriate medical providers that provide these services. So it requires some constant ongoing coordination among all the parties. Certainly child protection will tell us that all of their children get the initial health screening. We have to collect that documentation. Next slide. One of the mechanisms that we use, and this is a responsibility that the local county health departments are providing. We call them Health Works lead agencies. They have a number of very specific responsibilities. The first is a gathering of prior health records. The second is working with the caregiver and the caseworker to schedule a child for the comprehensive health evaluation. Another is that they work with the caregiver to follow up on any further evaluations or services that the child needs. Next, we ensure that they are linked to a primary care physician who is qualified to see the children, and these are physicians that are already within the network. In 2015, of the total number of children in out-of-home placement, which was just under 15,000, 97% of those children have a PCP selected. The explanation of the 3% is children are constantly coming into our custody, and it takes perhaps several weeks to work with the caregiver to select a doctor or to identify who the child's doctor is. Next slide. The next requirement in the program is the comprehensive health evaluation, and this is the opportunity or the event to further identify a child's health care needs, and this is really provided to the child within the first several weeks of their coming into custody and being in a placement. It's important, as Dr. Szilagyi has mentioned, that there's an established relationship with a new caregiver, so that child has some ability to settle down and then have a comprehensive evaluation. It also then leads to the development of a comprehensive health plan for that child, so that further needs are identified and evaluations can be scheduled. In 2015, that was a total of 4,152 cases, and our documentation is that 92% of those received a comprehensive health evaluation. And then within the requirement of 21 days within temporary custody, it was 64%. And let me just comment about that percent as well. The 21 days is something that's required by our federal court consent decree. It is a challenge, certainly, to ensure that children receive this evaluation within the 21 days. We use community health resources, physicians in the community, that have private practices or community health centers. And so sometimes the time frames are we don't really meet these time frames. We have to compete with physicians in their practices who are already seeing other children in the community, particularly when we're preparing for school. We have to compete with everyone else that's getting a physical exam for school. For appointment, we compete for appointments, during flu season. So there are a number of challenges here, and it also requires us to have a fairly close coordination and collaboration with the caseworker and the caregiver to make sure that all these things are scheduled and completed. The next slide.
And this is Paula again. As Moira said earlier, there's really three parts to health when we talk about children. We talk about developmental, physical, and behavioral mental health. So we've been focusing on their physical health, but for all our kids that walk in the door, they have a developmental health assessment. They have a behavioral mental health assessment. These are done by child psychologists. They meet with the family. It's called the integrated assessment. Their CANS is done. The Child and Adolescent Needs and Strengths is done for each child. And at 35 days, there is the family and the caseworkers sit down together and develop a family service plan of going forward for this child. So that, in a way, completes all the initial evaluations of the children. Now, I want to talk about, which I think is very important, is health information system. It is when you develop a system, you have to know, does it work? And we did not have a health information system. And about 5 years ago, the light bulb went on and said, there is SACWIST, a statewide automated child well information system. That is what the caseworkers do to input. It's a health information system for them to manage their cases. We also said the state, our state, as all states, collect health information about the children that they care of. So we did data sharing agreements with Medicaid for their health claims, not their health paid claims, but as soon as the claim comes in, because some states it takes 3 months, 6 months, 12 months to get them paid, and we wanted as up-to-date information as we could. So we wrote one with Medicaid. We wrote one with public health, where we could get birth certificates, neonatal screens, APORs, that's the adverse pregnancy outcomes and reporting systems. So they agreed. And then there was human services. Again, immunization, both from the private and the public sector. They have information about developmental testing, and they have information about pregnancy. And so we say we want to have all this information, which is a health information then, dumped into, if you will, SACWIST on a weekly basis. We met with our information system people within DCFS, our Child Welfare Agency, and said we want to design a health part of SACWIST for us to be able to have a health information system. So we designed it with them. They mapped these things appropriately. I'm a pediatrician. I don't understand all they do. But that gave us a health information system where we could then look at and help with the children. So what does the health information system show us? Two things. Next slide, please. They helps us about health information about the children. Hold on. I'll show you as soon as we get the next slide. So we can look at individual health information. About 70% of our kids who walk in the door to DCFS have been on Medicaid. So we can get all of their past medical history. About 30% come from the private sector, private health insurance. So we've met with the 7 major ones, Blue Cross Blue Shield and so forth and so forth. And for many reasons, they could not or would not give us the child's past medical information from the private sector. But we do have that all from Medicaid. We can then develop, besides a health information system, we can develop a summary of the child's medical problems, and what we call the health passport. As they say, this is designed that is updated on a weekly basis. This health passport is then given to the foster parent, who then takes it to see the physician, the primary care physician. It is given to the child if he goes back home. It is given to those that emancipate. It is given to the children at age 14 years of age, that we give it to them at 14 as we begin to say transitioning, and this is your health issues. And we give them on a yearly basis. Now, we are working on a web portal so the physicians and the emergency rooms and the hospitalizations can be able to pull up this data when they see that child in the clinic or in the hospital. So that's in the future, but that's what we want to do. So with these now individual health information, we can identify children in problems or having problems or in crisis. So, for instance, we can figure out children who have asthma. And so we call asthma out of control if they've been hospitalized or seen in the emergency room in the last 3 to 6 months. And then what do we do about that? We can then figure out, does this child need more? Does the foster parent need more? Does the child need more information about asthma? So we can send our nurses, our DCFS nurses, into the home to help with education, identifying barriers, identifying problems in the home, such as smoking, pets, etc. And the idea is that we can identify individual needs for these kids. The second thing that we can do is we can take our health data to measure how well is this system working, healthcare utilizations, and to a certain extent, some health outcomes. And it's again, to be able to say, is this system working? What can we identify? What are the problems? And to add to this, when we looked at asthma, and we specifically looked, because that is the number one chronic disease our kids have, and we drilled down to look at kids in home settings versus kids in congregate care. And kids in home settings, when we look at them, they do far better. Home setting is kinship care, traditional or specialized foster care. They do far better with their asthma than other kids in Medicaid, significantly have less hospitalizations and less emergency room visits. We also then looked at congregate care, and those kids did very poorly, as you could guess. 6 times more likely that they are to be hospitalized than other children in Medicaid. So just one of the things we've done is do congregate care report cards so we can notify the presidents and the CEOs of the congregate care, the residential, saying this child has not had their flu shot, this child has not seen a physician, this child does not have their asthma action plan, et cetera, et cetera. So that's one of the positive things we can do. So then we can also measure our healthcare utilization outcomes via CHIPR. That is the Children's Health Insurance Program, Reauthorization Act, and the states have to give their health information to the federal government. We also can compare our results with HEDIS, which is the Healthcare Effectiveness Data and Information System. And so we can identify, again, ways to improve. So we've looked at the 15 general pediatric healthcare quality measures. And I'm going to show you 2 of them, which are coming up. And all 15, and I can say happily, that we beat what other kids in Medicaid do. We beat both the Illinois and the United States. And here's a quick one. These are our young kids. They need to see the pediatricians or the family physicians to see how well they're doing. And if you look at 6+ visits, it's the United States, again, these are children, 60%. In Illinois, it's 72%. And in HealthWorks of Illinois, 82% of our kids are seeing the physician with 6 visits or more in their first 15 months of life. Next one. We also look at immunizations, and we can see from our immunization one that, again, we look at the younger kids, our 19 to 35 months, and again, looking at how their basic immunizations, how well they are doing, and you can see 74 and 68 and 90%. These are old 2013 CHIPR data. It takes a while for it to come out, and I can say in the fiscal year 2015, our number for these kids are about 93%. So it's a good way to say, does it work? Believe me, this is not perfect. We're trying to figure out better ways to help our kids. One of the issues is how do we measure well-being? Anyway, so I am going to end there because leave it open, and I want to thank you for listening. And you see my contact information. So we've learned a lot over the last 25 years. So if there's anybody who wants to, feel free to contact me.
Paula can be reached by phone at 773-753-8627 or via email at paula.jaudes@illinois.gov.
I would be happy to talk with you, and I wish you all good luck. And I'm turning it back over to Millicent.
Thank you. Just thanking you to all of the presenters who did a marvelous job with a lot of information in a short time. And we are going to open it up now for questions and answers.
And just a reminder to folks on the line, the audience is muted at this time. We encourage folks to use the questions feature in the GoToWebinar pane. Please type in your questions, and we'll be able to answer those. And our first question is about PowerPoint. The PowerPoint will be available at the conclusion of this presentation, so we will send that out. And I'll turn it back over to Millicent to chat about the evaluation.
Okay, great. While we're waiting for what I hope will be at least a couple of questions, we will be sending you out an evaluation of the webinar. And it only takes a few minutes to fill it out, and believe me, it's very helpful to us as we're planning future webinars, and it's immensely helpful to our panelists in terms of their presentations, which were very, very informative. But you will be receiving that information soon after the webinar is completed. And do we have any questions that came in?
Yes, we received several questions. The first one from Constance. What kind of challenges does the program meet with primary medical providers to meet the needs of children in care?
And I guess that could go to either of our presenters who would be willing to answer that.
Can you say the question again?
Sure. What kind of challenges does the program meet with primary medical providers to meet the needs of children in care?
I think I don't quite understand the question. What kind of
the challenges for the primary medical providers
in taking care of children in foster care? Well, I would say the challenges are immense, but they are certainly surmountable. And so, for example, I think what Paula's group has done in Illinois with creating communication systems and approaches that make it feasible for primary care pediatricians to take care of children with often very complex needs is great. Often it does require a change in systems. The visits are often lengthier. Often you have more visits in order to kind of take care of things. Just from a practical viewpoint, in the office setting, often you don't receive reimbursement for the intensity of the services that these children need. And so pediatricians do have to make kind of an extra commitment that they're willing to serve this population, despite the fact that they're probably going to lose money on the visit. And I think that those are, the unfortunate but very real challenges of practice. And I think that setting up systems of communication, it's often very hard for the pediatrician to know how to reach out to child welfare. So some of these issues really have to be solved at kind of a leadership level, which, we did kind of at the local level in Rochester, New York, and other places have done this also. We're not the only place that's done this. And I think, this is what Paul has done so well in Illinois, is identifying what the systems barriers are and then working to solve the systems barriers in a way that, the systems are created and then the local pediatrician can use that system to get information back to child welfare and vice versa.
Thank you. Our next question is for Paula and Vincent. Gamal asks, during the webinar it was stated that Illinois has a statewide health care plan for foster children called HealthWorks. Do you know, is the health care plan similar to the Child Health Program of New Jersey?
Whether it's similar, I don't know I'm not familiar with what New Jersey's system is. Our program is administered, and we didn't really get into this, but the program is really the financing of it is a combination of dollars that the Child Welfare Agency has to support the administration of the program, and that's funding to the local county health departments to provide the care coordination. The Healthcare and Family Services is really the Medicaid agency, so they pay for each of the individual services children get, and then we partner with Human Services. They're the Title V, and they provide a specialized medical case management service.
This is Paula. This is a PPO model of connecting the dots that way. I think, and I could be wrong, maybe Moira knows, I think New Jersey is more of a managed care entity unto itself, and I think that is, we do all the, I should say, quote, managed care within DCFS versus a separate entity. But even, and I just want to add about this, some states are going to managed care for our kids, and they have done very well, like Texas, where there's one entity that the state contracts with. And I think that there's also, and this is a plea for a medical director, I think they also need to have, the child welfare agencies need to have medical directors so they can oversee and ask the managed care, show me your data, show me how well you're doing with our kids and so forth. But that's Paula's opinion about that.
Yeah, and I think that's the opinion of the American Academy of Pediatrics Council on Foster Care, Adoption, and Kinship Care also.
That's right. I should say I sit on Moira chairs it, and I sit on that council also.
Yeah, I think this is something that we very strongly believe in. And I don't know what New Jersey's model of funding is. I think that many of the children are seen as part of their child advocacy centers, that they've tried to link medical home care and evaluation sites to each of those. And there are many different approaches to this. Utah has a nurse case management system where nurses sit literally with their child welfare teams at the regional level, and they have a very well-developed computer tracking health monitoring system for tracking the kids' utilization of services and making sure that they get the services that they need. Vermont has a system. So there are a lot of different models around the country. Massachusetts has kind of a state-level oversight system. So I would probably encourage folks, especially the state child welfare directors, to probably explore with their friends what systems are viable in some states and how well they're working and whether it is meeting the needs of children.
Hi, this is Millicent. Just in lieu of time, I know there's a lot of information that people have and want, and we will continue this discussion. If you have questions that you submitted and they weren't able to be answered on the call, we will answer your questions and get back to everyone with those answers. There is also resources that we have provided as part of the slide presentation, links to various resources on related to the information that the presenters have presented today.
You may access these resources online at https://capacity.childwelfare.gov.
And we also, again, will refer you to, can we advance the slide? If not, we can refer you to the website for the Capacity Building Collaborative, and there will also be more information there.
That's https://capacity.childwelfare.gov.
The presenters have been wonderful by evidence of how much expertise you have and how long you've been working on this area. I just hope that people out there will be able to take, what we shared today on this webinar and begin to implement or enhance what your practice around healthcare issues for kids in care. So we have come to the end of our time. And again, I want to thank the presenters and thank you, the participants who are out there listening to this information.